Question 1. An unresponsive patient is found lying prone, face down on a busy street. After ensuring the scene is safe, what is the next priority action?
A.
Perform a rapid secondary assessment.
B.
Establish an airway by performing a head tilt/chin lift maneuver.
C.
Apply a cervical collar before moving the patient.
D.
Manually stabilize the head and roll the patient to a supine position. Answer: D. Manually stabilize the head and roll the patient to a supine position. This question tests the foundational concept of scene management, particularly the critical action taken for an unresponsive patient in a dangerous, prone position. The keywords unresponsive and prone dictate the need for immediate intervention to assess and manage the airway, which requires the patient to be supine, face up. The next priority after confirming safety is manual stabilization of the head and a careful log roll to protect the spine while moving them to a position that allows for primary assessment and airway control. This action is crucial because a patient cannot be properly assessed or resuscitated while lying on their stomach, especially on a busy street. Here is an easy way to remember it. You cannot manage the airway breathing circulation, IBC, of an unresponsive patient until they are safe and lying supine. Question 2. The proper chest compression rate for an adult patient in cardiac arrest, according to current American Heart Association guidelines, is
A.
80 to 100 compressions per minute.
B.
100 to 120 compressions per minute.
C.
120 to 140 compressions per minute.
D.
At least 60 compressions per minute. Answer: B. 100 to 120 compressions per minute. This item tests knowledge of current high-quality cardiopulmonary resuscitation (CPR) guidelines, with the key phrase compression rate focusing on the correct speed of chest compressions. The most recent guidelines specify a compression rate of 100 to 120 compressions per minute to ensure adequate blood flow to the vital organs during cardiac arrest. Performing CPR within this range is a core component of high-performance resuscitation and directly impacts patient survival rates. A simple way to remember this is to compress to the beat of a song like Staying Alive, which falls within the 100 to 120 beat per minute target range. Question 3. A 68-year-old male presents with sudden onset of slurred speech and weakness on the right side of his body that completely resolved within 20 minutes of your arrival. This presentation is most consistent with A. Ischemic stroke.
B.
Hemorrhagic stroke.
C.
Generalized seizure.
D.
Transient ischemic attack. T. Answer: D. Transient ischemic attack. T. This question evaluates the understanding of neurological emergencies, specifically differentiating between a stroke and a transient ischemic attack, TIA, with the critical clue being that the symptoms completely resolved within 20 minutes. A TIA is often called a mini-stroke because it involves temporary neurological deficits caused by a brief blockage, and by definition, symptoms resolve completely without permanent damage. Unlike a full stroke, which causes lasting deficits, a TIA is a temporary event but must still be treated as a medical emergency because it serves as a strong warning sign for future, more debilitating stroke. Remember that TIA stands for transient ischemic attack, where transient means temporary. Question 4. What is the maximum amount of time you should suction the airway of an adult patient before reoxygenating?
A.
5 seconds.
B.
10 seconds.
C.
15 seconds.
D.
20 seconds. Answer: C. 15 seconds. This drills the critical skill of airway management, specifically the safety limits for suctioning the upper airway, with the keyword maximum amount of time, highlighting the need for a precise number. Suctioning an adult should be limited to no more than 15 seconds at a time because the procedure removes not only foreign material but also oxygen from the patient's lungs. Limiting suctioning time minimizes the risk of hypoxia, which is a dangerous drop in blood oxygen levels, and reassessment and reoxygenation must occur before another attempt. A good practical rule is to suction only as you withdraw the catheter, visually guiding the process, and strictly keeping the duration under 15 seconds. Question 5. You are treating a 35-year-old construction worker who has been sweating profusely, has cool, pale skin, is dizzy, and reports muscle cramps after working in direct sun for 8 hours. His vital signs are stable, but he appears weak. This presentation is most indicative of
A.
heat stroke,
B.
heat exhaustion,
C.
hypothermia, D. hyperglycemia. Answer: B. heat exhaustion. This question tests the ability to distinguish between environmental emergencies, with the key presentation of cool, pale skin, and profusely sweating being crucial differentiators. Heat exhaustion is a milder heat illness caused by water and salt loss, characterized by heavy sweating, dizziness, and normal mental status, which is exactly how the construction worker is presenting. In contrast, heat stroke is a life-threatening emergency where the body's cooling system fails, resulting in a cessation of sweating and an altered mental status. An easy way to distinguish between the two is that in heat exhaustion, the patient is often still sweating and thinking clearly, but in heat stroke, the body is so overheated it cannot sweat, and the brain starts to fail. Question 6. Which of the following is an absolute contraindication for administering oral glucose to a suspected hypoglycemic patient?
A.
History of diabetes.
B.
Blood glucose level above 70
Slash.
dl, 70 milligrams per deciliter.
C.
Inability to swallow or altered mental status.
D.
Patient is under 18 years of age. Answer: C. Inability to swallow or altered mental status. This covers the EMT scope of practice and pharmacology for diabetic emergencies, with the crucial keyword absolute contraindication, indicating a condition that makes the medication definitively unsafe. Oral glucose is administered to conscious patients who can safely swallow and protect their own airway to rapidly raise their blood sugar level. Giving a thick, sugary substance to a patient with an altered mental status or one who cannot swallow significantly increases the risk of aspiration, which is when the substance is breathed into the lungs, leading to a severe respiratory complication. Therefore, if the patient cannot safely swallow, the EMT must choose an alternative treatment, such as seeking advanced life support to establish in 4. Question 7. You arrive at the scene of a motor vehicle collision and find a patient trapped in the driver's seat. Before attempting to access the patient, your first priority in the primary assessment must be
A.
Determine the patient's Glasgow Coma Scale, GCS score.
B.
Assess the patient's radial pulse and skin condition.
C.
Ensure scene safety and take body substance isolation, BSI precautions.
D.
Request an air medical transport unit. Answer: C. Ensure scene safety and take body substance isolation, BSI precautions. This question addresses the essential first step of emergency operations, specifically emphasizing the immediate actions taken upon arriving at any scene, where the keyword first priority is the vital clue. Before approaching or touching any patient, the EMT must confirm the environment is safe from hazards, like traffic or leaking fuel, and put on appropriate personal protective equipment, PPE, like gloves and eye protection. Scene safety and BSI are foundational to patient and provider well-being and always precede hands-on patient care and assessment, following the principle of your safety first. Always remember that the most capable rescuer is the one who is safe and uninjured. Question 8. In trauma care, what is the primary purpose of applying a triangular binder, cravat dressing to an evisceration?
A.
To apply direct pressure to stop bleeding.
B.
To hold the organs back into the abdominal cavity.
C.
To keep the exposed organs warm and moist.
D.
To firmly immobilize the patient's torso. Answer: C. To keep the exposed organs warm and moist. This tests specific trauma dressing techniques for an evisceration, which is when abdominal organs protrude through an open wound, and the keyword primary purpose directs attention to the essential goal of this dressing. When internal organs are exposed to air, they are at high risk of drying out, desiccation, and becoming contaminated, so the goal is not to push them back or apply pressure. Instead, the exposed organs should be covered with a sterile, moist, non-adherent dressing, often secured with a triangular binder, to protect the tissue and prevent critical heat and fluid loss. The best practice is to always gently cover eviscerations with a moist dressing, never attempt to push them back, and then secure the dressing. Question 9. An EMT provides care to a patient who has explicitly refused transport after being advised of the risks of refusal. If the EMT leaves the scene without ensuring the patient is cared for by another appropriate healthcare professional or family member, the EMT may be liable for
A.
battery,
B.
negligence,
C.
abandonment,
D.
breach of confidentiality. Answer: C. Abandonment. This tests knowledge of the legal and ethical principles governing EMS care, with a scenario describing a situation where care is terminated without the patient being transferred to the care of someone equally qualified. Abandonment is the unilateral termination of care by the EMT without the patient's consent and without making provisions for continuing care, even after a patient has refused transport. Once an EMT initiates care, they have a legal duty to the patient, and leaving a patient who may still be at risk, even after a refusal of transport, can be considered legally negligent and an act of abandonment. The takeaway is to remember that initiating care creates a legal obligation, and you must complete a formal transfer of care to someone of equal or higher level of training. Question 10. Which condition is a definitive contraindication for the use of a nasopharyngeal airway in PAE?
A.
Unresponsive patient with no gag reflex.
B.
Suspected basilar skull fracture with cerebrospinal fluid leakage.
C.
Presence of a stoma.
D.
History of asthma. Answer: B. Suspected basilar skull fracture with cerebrospinal fluid leakage. This addresses the critical skill of airway management, specifically identifying when a nasal airway is dangerous, with the keyword definitive contraindication, emphasizing the absolute exclusion criterion. A suspected basilar skull fracture, evidenced by findings like raccoon eyes or battle sign or cerebrospinal fluid leakage from the nose or ears, is the primary contraindication for an NPA. Inserting a device into the nose could potentially enter the cranial vault through a fracture and cause direct brain injury. Therefore, any suspected facial or head trauma requires careful consideration and usually an oropharyngeal airway, OPE if appropriate. Question 11. What finding in a pediatric patient is considered the most reliable sign of compensated shock?
A.
Tachycardia, fast heart rate.
B.
Hypotension, low blood pressure.
C.
Bradypnea, slow respiratory rate.
D.
Altered mental status. Answer: A. Tachycardia, fast heart rate. This question focuses on pediatric assessment and the physiology of shock, where the keyword compensated shock means the body is still maintaining a normal blood pressure. Children's bodies are very efficient at compensating for blood loss by increasing their heart rate, tachycardia, and constricting blood vessels, which keeps their blood pressure normal until the very late stages. Low blood pressure is a late and ominous sign in children, meaning they are already in decompensated shock, so a fast heart rate is the most reliable and earliest indicator of shock you must identify. Remember that children crash fast, and their primary compensatory mechanism is increasing the heart rate, making it your most important initial vital sign. Question 12. A patient experiencing chest pain and shortness of breath is restless, pale, and diaphoretic. His blood pressure is 130/86, 130/86 mmHg, and heart rate is 110 BPM. 110 BPM. The patient is likely in which stage of shock?
A.
Irreversible shock.
B.
Decompensated shock.
C.
Compensated shock.
D.
Neurogenic shock. Answer: C. Compensated shock. This tests the ability to recognize the stages of shock, with the critical clue being that the patient is symptomatic, restless, pale, diaphoretic, but still maintaining a normal blood pressure. 130/86 mmHg. 130/86 mmHg. Compensated shock occurs when the body's mechanisms, like a fast heart rate and vessel constriction, are actively working to maintain adequate perfusion, successfully keeping the blood pressure within the normal range. The restlessness, paleness, and fast heart rate are the body's symptoms of working hard to compensate for poor circulation, indicating an early stage that requires immediate intervention before blood pressure drops. A practical clue is that as long as the blood pressure is normal, even with other bad signs, the patient is still likely in compensated shock. Question 13. Which action is an EMT legally authorized to perform under the standing orders or protocols for administering aspirin to a patient with chest pain?
A.
Administer an adult dose of 325 milligrams, enteric-coated.
B.
Administer 324 milligrams of chewable baby aspirin.
C.
Administer 81 milligrams if the patient is already taking a daily blood thinner.
D.
Administer only if the patient has a history of a previous heart attack. Answer: B. Administer 324 milligrams of chewable baby aspirin. This question focuses on the pharmacology and scope of practice for administering aspirin for chest pain, with the primary concept being the correct dosage and form. Most protocols authorize EMTs to administer for 81 milligrams chewable baby aspirins, totaling 324 milligrams, because the medication must be chewed for rapid absorption through the oral mucosa, quickly blocking platelet aggregation. Enteric-coated pills take too long to dissolve, and a history of blood thinners is not an automatic contraindication, making 324 milligrams chewable the correct standard. Always ensure the patient is not allergic and can safely chew and swallow the 4 baby aspirins. Question 14. What is the most critical difference in presentation between a patient experiencing heat exhaustion and one experiencing heat stroke?
A.
The presence of muscle cramps.
B.
The severity of the headache.
C.
The presence of an altered mental status.
D.
The heart rate being elevated. Answer: C. The presence of an altered mental status. This tests the ability to rapidly distinguish between 2 life-threatening environmental conditions, and the keyword, most critical difference, requires choosing the feature that signals a system failure. An altered mental status, such as confusion, disorientation, or unresponsiveness, is the key finding that defines heat stroke because it signifies that the body's core temperature has risen so high that the brain is no longer functioning normally. Both conditions can involve cramping and an elevated heart rate, but only heat stroke presents with mental status changes, indicating a life-threatening, true medical emergency requiring immediate, aggressive cooling. When in doubt, any patient with an altered mental status in a hot environment should be treated as a heat stroke emergency. Question 15. The 3 components of the pediatric assessment triangle, PAT, are
A.
Appearance, breathing, and circulation.
B.
Airway, breathing, and circulation.
C.
Level of consciousness, skin, and pulse.
D.
Vitals, history, and mechanism of injury. Answer: A. Appearance, breathing, and circulation. This question assesses the knowledge of pediatric patient assessment with the keywords Pediatric Assessment Triangle, P, specifically referring to the non-touch, rapid assessment tool. The PAT allows the EMT to quickly form a general impression of the sick or injured child from the doorway before touching them, using the 3 distinct components. Appearance, work of breathing and circulation to the skin. This initial assessment helps determine the severity of the child's condition and whether immediate stabilization is required, prioritizing intervention over a full physical exam. Remember that the PAT is visual, giving you the ABC assessment of the patient's condition, not the anatomical airway breathing circulation approach. Question 16. What physiological response is the goal when administering an epinephrine autoinjector to a patient in anaphylaxis?
A.
Peripheral vasodilation to lower blood pressure.
B.
Bronchodilation and peripheral vasoconstriction.
C.
Slowing of the heart rate and increased capillary permeability.
D.
Suppression of the immune system's histamine response. Answer. B. Bronchodilation and peripheral vasoconstriction. This question tests the understanding of the pharmacology of epinephrine for anaphylaxis with the keyword physiological response, asking what effect the drug has on the body. Epinephrine is a powerful drug that quickly reverses the two main life threats of anaphylaxis. It causes bronchodilation, which opens up the constricted lower airways, and peripheral vasoconstriction, which narrows the blood vessels to raise the dangerously low blood pressure. The twofold action of epinephrine is essential, as it allows the patient to breathe better and improve circulation simultaneously. Remember that epinephrine is the antidote for anaphylaxis because it directly fights both the airway swelling and the massive blood pressure drop. Question 17. Which sign is a component of Cushing's triad, indicating rapidly increasing intracranial pressure, ICP, in a trauma patient?
A.
Tachycardia, hypotension, and tachypnea.
B.
Bradycardia, hypertension, widening pulse pressure, and irregular respirations.
C.
Fast, shallow respirations, pale skin, and a thready pulse.
D.
Deep, rapid breathing, small respirations, fever, and warm skin. Answer. B. Bradycardia, hypertension, widening pulse pressure, and irregular respirations. This addresses the assessment of severe head trauma, specifically focusing on the ominous sign known as Cushing's triad, which indicates impending brain herniation. Cushing's triad is characterized by the specific set of symptoms: a slow heart rate, bradycardia, an increased blood pressure, hypertension with a widening pulse pressure, the difference between systolic and diastolic pressure, and irregular breathing patterns. Identifying this triad is an urgent warning sign of high intracranial pressure and requires immediate intervention and rapid transport to a trauma center. This pattern is easily remembered as the body's final attempt to perfuse the brain. The blood pressure goes up to push blood past the swelling, and the heart rate slows as a reflex. Question 18. A 40-year-old male with a history of alcohol abuse is actively seizing. After ensuring the scene is safe, what is your immediate priority?
A.
Apply high-flow oxygen via non-rebreather mask.
B.
Attempt to place a bite block in his mouth to protect his tongue.
C.
Pad the environment around the patient to prevent injury.
D.
Restrain the patient to prevent him from thrashing and hurting himself. Answer. C. Pad the environment around the patient to prevent injury. This tests the proper management of a patient experiencing a generalized seizure, where the keyword immediate priority directs focus to patient safety during the event. The most crucial immediate step during an active seizure is to protect the patient from physical harm by patting the objects around them and moving any sharp or hard items out of the way. You should never attempt to restrain the patient, force anything into their mouth, or hold them down, as this greatly increases the risk of musculoskeletal injury and vomiting, so simply protecting their environment is the safest intervention. Always remember that patient safety is paramount during an active seizure, and you must wait for the seizure to stop before administering oxygen or performing other assessments. Question 19. An unconscious patient is breathing 4 times per minute and has pinpoint pupils. What emergency medication should the EMT be prepared to administer based on standing orders?
A.
Oral glucose.
B.
Activated charcoal.
C.
Naloxone Narcan.
D.
Nitroglycerin. Answer. C. Naloxone Narcan. This focuses on pharmacology and recognizing the classic signs of an opioid overdose, where the combination of unconscious, pinpoint pupils, and a severely low respiratory rate of 4 times per minute is the definitive clue. Naloxone, commonly known as Narcan, is an opioid antagonist medication that is indicated to temporarily reverse the effects of opioid-induced respiratory depression. This is a time-critical intervention, as the patient's severely slow breathing indicates imminent respiratory arrest, which requires immediate administration of the reversal agent. Your key takeaway is that an unconscious patient with very slow breathing and pinpoint pupils is a presumptive opioid overdose, making naloxone the definitive drug of choice. Question 20. What is the most common potential complication when inserting an oropharyngeal airway, OP, in a patient who is unconscious but has a gag reflex?
A.
Increased risk of aspiration.
B.
Damage to the vocal cords.
C.
Laryngospasm, closing of the vocal cords.
D.
Vomiting and subsequent aspiration. Answer: D. Vomiting and subsequent aspiration. This question tests the essential skill of airway management and the proper use of mechanical adjuncts, with the keyword, most common potential complication, requiring knowledge of a major patient safety concern. Inserting an OPA in a patient who still retains a gag reflex will often stimulate the back of the throat, causing the patient to gag, which can rapidly lead to vomiting and the aspiration of stomach contents into the lungs. The OPA should only be used in unresponsive patients without a gag reflex, while the nasopharyngeal airway, NPA, is the better alternative if the gag reflex is still present. A critical rule to remember is, if a patient resists or gags when you attempt to place an OPA, you must remove it immediately. Question 21. A 72-year-old female reports a sudden onset of difficulty breathing, is coughing up pink, frothy sputum, and has crackles, rales in her lungs. She has a history of congestive heart failure, CHF. This is likely caused by
A.
a pneumothorax,
B.
right-sided heart failure,
C.
acute pulmonary edema,
D.
severe asthma exacerbation. Answer: C. Acute pulmonary edema. This tests the ability to recognize the classic presentation of a medical cardiac emergency, where the combination of the history of CHF, difficulty breathing, and the specific finding of pink, frothy sputum points to a definitive diagnosis. Acute pulmonary edema occurs when the left side of a failing heart cannot pump blood forward effectively, causing fluid to back up rapidly into the lungs, leading to the characteristic pink, frothy discharge and crackling lung sounds. This is a true emergency that requires immediate intervention, often including the use of continuous positive airway pressure, CPAP, to push the fluid out of the alveoli. The key takeaway is that pink, frothy sputum is a hallmark sign of severe fluid backup into the lungs due to acute heart failure. Question 22. In the context of a motor vehicle collision, what is the significance of the mechanism of injury, MY?
A.
It determines the level of spinal immobilization required.
B.
It establishes the definitive diagnosis before the physical exam.
C.
It is a warning sign that significant internal injury may have occurred.
D.
It provides the only necessary information for the transport decision. Answer: C. It is a warning sign that significant internal injury may have occurred. This question covers the trauma assessment and the importance of scene size up, with the keyword significance, emphasizing the practical use of the information gathered. The MY, such as a high-speed collision or a significant fall, alerts the EMT to the potential for serious, unseen internal or occult injuries that the physical exam might not immediately reveal. While it does not give a definitive diagnosis, a severe MY raises suspicion and dictates a higher level of vigilance, faster transport, and a more thorough assessment of the patient. Always consider a severe MY as a red flag that requires you to assume the worst until proven otherwise through a thorough assessment. Question 23. Continuous positive airway pressure, CPAP, is generally indicated for patients with severe respiratory distress caused by which condition?
A.
Closed head trauma with an irregular breathing pattern.
B,
Hypoxia secondary to an opioid overdose.
C,
Acute pulmonary edema or a severe COPD exacerbation. D, a tension pneumothorax. Answer:
C,
acute pulmonary edema or a severe COPD exacerbation. This assesses the knowledge of non-invasive positive pressure ventilation with the key term CPAP, indicating its specialized role in respiratory management. CPAP is an advanced treatment used for spontaneously breathing patients in severe respiratory distress, most commonly caused by acute pulmonary edema, fluid in the lungs, or a severe chronic obstructive pulmonary disease exacerbation. The positive pressure helps to push fluid out of the alveoli and keep the small airways open, significantly improving oxygenation and the patient's work of breathing. The main requirement for using CPAP is that the patient must be able to protect their own airway and be alert enough to follow commands. Question 24. A patient has a laceration on the forearm that is spurting bright red blood. Which is the most appropriate initial intervention to control this life-threatening hemorrhage?
A,
Apply a tourniquet immediately proximal to the wound.
B,
Apply a hemostatic dressing directly into the wound.
C,
Apply direct pressure with a sterile dressing.
D,
Elevate the extremity and check a distal pulse. Answer: C. Apply direct pressure with a sterile dressing. This tests the standard protocol for hemorrhage control, where the keyword initial intervention emphasizes the first step in the bleeding control algorithm. The most immediate and standard first intervention for external bleeding is to apply direct, firm pressure with a sterile dressing, which helps the blood to clot and seals the damaged blood vessel. If direct pressure is insufficient, then a tourniquet is the next appropriate step for life-threatening extremity hemorrhage, but direct pressure always starts the process. Remember the sequence. Direct pressure, then if bleeding is uncontrolled, apply a tourniquet. Question 25. The medical term for a massive, life-threatening allergic reaction is A. Angioa.
B,
Anaphylaxis.
C,
Urticaria.
D,
Hypersensitivity. Answer: B. Anaphylaxis. This is a straightforward knowledge check on medical terminology, where the description, massive, life-threatening allergic reaction, is the definition of the term being sought. Anaphylaxis is a severe, systemic allergic reaction that involves multiple body systems, specifically the respiratory and circulatory systems, which leads to airway swelling, laryngeal edema, and dangerously low blood pressure, shock. This condition requires immediate intervention, primarily with the administration of epinephrine. The key takeaway is that anaphylaxis is the only term that represents a full-blown, systemic, life-threatening allergic reaction. Question 26. When assessing a 3-year-old patient, what is the appropriate method for evaluating capillary refill time?
A,
Press firmly on the skin of the forehead.
B,
Compress the fingernail bed for 5 seconds.
C,
Compress the sole of the foot or the skin on the knee.
D,
Check the pulse oximeter reading on the earlobe. Answer: C. Compress the sole of the foot or the skin on the knee. This addresses the specialized assessment techniques required for pediatric patients, with the key phrase 3-year-old patient, indicating the need for an approach appropriate for a nonverbal child. In infants and young children, checking capillary refill by compressing the sole of the foot or the skin over the kneecap is the most reliable, non-frightening, and practical technique, as their hands and feet may be cold from the environment. This assessment helps evaluate peripheral perfusion and shock, with a normal refill time being less than 2 seconds. Remember that in a child, you must always choose a technique that causes minimal distress while still providing accurate information. Question 27. What is the most critical intervention for a patient with a tension pneumothorax?
A,
Applying a non-rebreather mask at 15
L/N
15 liters per minute to maintain SpO2 above 94%. 94%.
B,
Immediate placement of an occlusive dressing over the open chest wound.
C,
Needle decompression performed only by a paramedic or higher-level provider.
D.
Application of a continuous positive airway pressure, CPAP device. Answer: C. Needle decompression performed only by a paramedic or higher-level provider. This tests the recognition and definitive treatment of a life-threatening thoracic trauma, where tension pneumothorax causes pressure to build up, collapsing the lung and shifting the mediastinum. The most critical intervention to relieve this pressure is a needle decompression, which is a procedure that allows the trapped air to escape and must be performed immediately by a paramedic or other qualified provider under medical direction. While EMTs cannot perform the decompression, they must recognize the signs, such as absent breath sounds and tracheal deviation, and rapidly transport the patient. Recognizing the condition is an immediate life threat. The key takeaway is that a tension pneumothorax is a pressure emergency, and that pressure must be released immediately with a needle to save the patient's life. Question 28. Which of the following best describes the principle of do not resuscitate, DNR or physician orders for life-sustaining treatment, POLST documentation?
A.
It is a binding legal document that must be honored only if signed by the patient.
B.
It is a medical order that must be honored if properly completed and presented to the EMT.
C.
It is a request for comfort care that allows the EMT to stop CPR once it is started.
D.
It is an unofficial document that only applies if the patient is terminally ill. Answer: B. It is a medical order that must be honored if properly completed and presented to the EMT. This question covers the legal and ethical responsibilities regarding end-of-life care, focusing on the authority of advance directives. A DNR or POLST is a specific type of legal medical order that must be accurately completed and presented to the EMT, and it dictates that the provider must withhold certain resuscitative measures, such as chest compressions or defibrillation. These documents are legally binding medical orders that define the scope of care, and EMS providers are obligated to follow them once they are verified, regardless of the patient's terminal illness status. Always remember that a DNR is a medical order, not just a request, and you must confirm its validity before withholding resuscitation. Question 29. A patient with severe hypoglycemia, low blood sugar, is awake but confused and unable to swallow. The EMT should:
A.
Place the patient in the recovery position and wait for a paramedic unit.
B.
Place a small amount of oral glucose gel between the patient's cheek and gum.
C.
Administer high-flow oxygen via non-rebreather mask and transport.
D.
Immediately establish N4 and administer D50W. Answer: B. Place a small amount of oral glucose gel between the patient's cheek and gum. This addresses the intervention for a diabetic emergency where the patient cannot safely swallow, testing the knowledge of alternative routes for glucose administration within the EMT scope. When a hypoglycemic patient is alert but unable to swallow safely, the EMT is typically authorized to administer oral glucose by rubbing the gel between the cheek and gum, buccal route, to allow for slow absorption through the oral mucosa. This is the only safe way to administer glucose at the EMT level when the patient is at risk of aspiration, while establishing N4 is an advanced skill. Remember that the buccal route is a safe way to administer glucose to a conscious but unreliable patient. Question 30. Which term describes the condition when the body's internal temperature falls below 95? Ring operator. F. 35. Ring operator.
C. A.
Heat stroke.
B.
Hypothermia.
C.
Hyperthermia.
D.
Febrile seizure. Answer: B. Hypothermia. This is a direct definition question regarding environmental emergencies, where the key is knowing the low temperature threshold for this specific condition. Hypothermia is defined as a core body temperature that drops below 95. Ring operator. F. 95. Ring operator. F. 35. Ring operator.
C.
35. Ring operator.
C.
Which begins to impair normal bodily functions, particularly the brain and heart. This condition requires immediate and careful removal from the cold environment and the implementation of active and passive rewarming techniques, depending on the severity. It is crucial to remember that hypothermia can affect people even in moderate temperatures, especially the elderly or those with underlying illness. Question 31. What is the critical priority when managing an open or sucking chest wound?
A.
Immobilize the rib cage with a chest binder.
B.
Place a sterile, gauze dressing loosely over the wound.
C.
Seal the wound with an occlusive dressing taped on 3 sides.
D.
Perform immediate needle decompression. Answer. C. Seal the wound with an occlusive dressing taped on 3 sides. This addresses the critical skill of trauma management for a penetrating chest injury, with the keyword open or sucking describing a wound that allows air into the chest cavity, pneumothorax. The critical priority is to immediately seal the hole with a non-porous, occlusive dressing like plastic wrap or a special commercial seal, and tape it on only 3 sides, creating a flutter valve. This valve allows air to escape from the chest cavity, but prevents air from being sucked back in, effectively managing the developing pneumothorax. Never tape all 4 sides, as this converts the injury into a dangerous tension pneumothorax by trapping the air inside. Question 32. In the initial assessment of an unresponsive adult patient with no suspected trauma, the preferred method to open the airway is the
A.
jaw thrust maneuver.
B.
Sellick maneuver.
C.
Head tilt/chin lift maneuver.
D.
Recovery position. Answer. C. Head tilt/chin lift maneuver. This question tests the foundational skill of primary assessment, focusing on the non-trauma method for airway opening, with the key phrase, no suspected trauma, providing the critical clue. The head tilt/chin lift maneuver is the quickest and most effective method for opening the airway in an unconscious patient by lifting the tongue off the back of the throat. This technique is contraindicated only when a spinal injury is suspected, in which case the jaw thrust maneuver is used instead. Always begin with a head tilt/chin lift unless there is any indication of neck or spinal injury. Question 33. Which finding is the most reliable sign of decompensated shock in an adult patient?
A.
Tachycardia.
B.
Blood pressure below 90 millimeters of mercury. Systolic.
C.
Altered mental status.
D.
Pale, cool, clammy skin. Answer. B. Blood pressure below 90 millimeters of mercury. Systolic. This tests the ability to recognize the progression of shock, where the keyword decompensated shock signifies the stage where the body's compensatory mechanisms have failed. A blood pressure that falls below 90 millimeters of mercury. Systolic in an adult is the definitive, late-stage sign that the circulatory system can no longer maintain adequate pressure to perfuse vital organs, especially the brain. While tachycardia and altered mental status are key findings in earlier stages, the drop in blood pressure marks the transition to the most critical, life-threatening stage of shock. Remember that once the blood pressure drops, the patient is in severe, life-threatening shock and requires immediate, aggressive treatment. Question 34. How should you properly measure an oropharyngeal airway, OPE, for insertion into an adult patient?
A.
From the corner of the mouth to the center of the earlobe.
B.
From the tip of the nose to the angle of the jaw.
C.
From the center of the earlobe to the tip of the chin.
D.
From the incisor teeth to the angle of the jaw. Answer. A. From the corner of the mouth to the center of the earlobe. This covers the essential, practical skill of correctly sizing an airway adjunct, with the key being the anatomical landmarks used for proper measurement. An OPA is properly sized by measuring from the corner of the patient's mouth to the center of the earlobe, or from the center of the incisor teeth to the angle of the jaw, ensuring the device is neither too long nor too short. A device that is too small will not hold the tongue forward, while one that is too large can push the epiglottis down and block the airway completely. A simple, Practical tip is that the correct size OPA will closely match the distance from the mouth to the earlobe. Question 35. You are transporting a critical patient when you receive a call from medical direction stating that the transport must be diverted to a different hospital due to capacity issues. This is an example of what component of the EMS system?
A.
Quality assurance.
B.
Public health.
C.
Disaster management.
D.
Medical direction/control. Answer: D. Medical direction/control. This question addresses the operational and systemic structure of EMS, with a scenario describing a direct order that changes the course of patient management. Medical direction, or medical control, is the physician oversight, either online direct radio/phone communication or offline protocols/standing orders, that governs all clinical aspects of patient care within an EMS system. A physician ordering a hospital diversion is a direct example of online medical direction exerting its authority over patient flow and resource management. Remember that medical direction is the doctor in charge of the patient's care, even if they are miles away, and their orders must be followed.